Um, Sweet. All right, Andy, can you give like a brief little background on yourself and then we'll roll into it?
Yeah, what's going on, guys? I'm Andy. I'm a physical therapist in New York City. I practice for Reload PT. And one of the reasons I decided to pick this paper and this topic in general is it's because something that I was personally lacking. Coming into like physical therapy, my mind was all powerlifting. And I didn't realize that while it's a great, intervention in itself, I think there needs to be a gap that needs to be bridged when you're returning to sport, when the speeds and everything are much quicker. So powerlifting was good for building that foundational strength, but transitioning to return to sport was a different game. So when I started diving into the topic, this is one of the papers, well, two of the papers that I found really impactful to how I practice now.
Perfect. So it's completely up to you which paper you want to start with, or if you want to kind of blend both of them because they were very similar in a sense.
Yeah, I think the first thing is one of the, I'll go with the newer paper just because for me, that had more information and it kind of had, I'm just going to pull that up right now. The newer paper, I think, had most of the more practical information, whereas the one from 2003 was a little bit more theory. So the 2017 one, lower extremity stiffness considerations for testing, performance enhancement, and injury risk. I'm just going to dive into that one a little bit. I have a couple of points highlighted, and I was talking to Chris a little bit earlier, but whenever I'm reading research, I try to get something out of it that I can apply immediately in the clinic. So I just want to pull up a quote that I thought was really, really interesting. Everything, I'm a terrible highlighter, so like everything is literally highlighted. Uh, all right, and it's right in the beginning. So cumulative body evidence indicates that increases in lower extremity stiffness are associated with heightened performance in athletic tasks such as hopping, jumping, throwing, endurance running, sprinting, and changing directions. Relationships with injury are less conclusive as both an excessive and insufficient limb stiffness have postulated to increased risk. So coming like right away, diving into that, I'm always immediately thinking about what is this person in front of me lacking? So coming into the clinic, if someone's been, non-weight bearing, someone's been injured and not utilizing that lower extremity for a longer period of time, to me, that's like, okay, this person probably lacks some, stiffness in the lower extremity in order to recycle energy. So once we get into the clinic and, you get someone's story, I'm immediately looking at someone's capacity to start tolerate plyometrics. So the first thing I'll do is, look at low level bounces and things like that to see how they handle, the particular stimulus. For me, when someone comes in with like knee pain, hip pain, back pain, it's very easy to start treating the site of the symptoms, but looking at how everything works in coordination, it plays a huge role. And I just kind of like open up to you guys, like how do you guys incorporate like lower extremity stiffness with your clients and your athletes in the gym or clinic?
Yeah, I'll kind of start us off. I see a lot of post-op patients, so whether that's post-op ankle or knee, we don't see too many hips. So typically when I'm doing any kind of stiffness related activities, it's usually post-op. So just trying to get them through a good progression of strength. I like lower tempos, strength at higher tempos. And then kind of over the years, I've played around with various progressions that I've taken from like an exos course that I took, some of like Dan Canton stuff that I've watched just like here and there. So working on just like deceleration first and doing some like low level like snap downs, maybe like ankle specific little hopping task, and then working into like skipping, like any kind of like agility ladder work, and then gradually progressing like intensity with plyometrics, and then progressing double leg to single leg. So that'd be kind of overarching, I think, how I approach this.
Shelby, Shelby or Andy, when you're progressing from all of those, is it in the back of your head like I'm trying to increase stiffness qualities, or are you like I'm trying to return them back to the demands of the sport?
Yes.
Both.
Yeah. Yeah. So like a sport like basketball and volleyball that involves a lot of jumping, right? It's going to be different than if I'm working with a girl like going back to shot put, right? Like she needs to generate stiffness, but from like a different aspect than like a trying to just get vertical. It'd be like trying to get transverse plane stiffness so that she can actually throw the shot put far. So depends on the sport. And then we just now got force plates, so we haven't had like a good way to test one leg versus the other leg, like objectively stiffness. So it's been a lot of eyeballing or using like the My Jump app to try to get them as symmetrical as possible.
Yeah, I'm doing the backpack kind of on Shelby said, and for me, it's just kind of looking at what the person's demands are. So let's say someone's a sprinter or runner, then the demands are very, well, if someone's a sprinter, then the ground reaction times are very short. So I need to get them to the point where they can tolerate that. So something as simple as doing a double leg pogo, seeing how well they tolerate it. And the progressions are very similar, double leg pogo, stationary, maybe locomotive, then you do single leg, and you're just kind of trying to elicit this person's symptoms and then kind of connect it back to their story. So that's kind of where I got with this paper when I was reading. It's like, oh, wow, someone might be having a knee, experiencing knee pain or hip pain, but could be coming from, inability to utilize the storage and release from the tendons. So it's always connecting it back to the person's story and then figuring out what their current capacity is. And if some of their symptoms are reproduced during these activities, then that's a KPI, and that has to improve in order for them to get back into their set sport.
Prefacing this with I'm still in school, but I work with a bunch of personal training clients that all ended up with me because they are in pain. So I try and like marry those two things together. And in particular, I enjoyed reading both of these papers. And I think I was kind of exposed to this concept a little bit over the summer through my clinical at Resilient, actually. I was in New Jersey. I was supposed to be in New York, but COVID. Like classifying people into very elastic people versus very non-elastic people. And so, for example, I'm working with a client right now. He's in his mid 50s. He has episodic back pain, but he is very intolerant to any kind of impact. So even like, for example, a low level pogo, he cannot do that. So I've tried to really like tease out in the middle of figuring out, okay, to me, this person is actually too stiff in general. Like everything he does is really stiff. And so how can I expose him to, and this is something that I'm definitely struggling with. And I enjoyed reading these because I think it gave me a little bit more perspective. But how can I tease out kind of the middle ground of, all right, what can I grade? So he can't do a pogo, fine. He can do like a bilateral snap down, but only if it's at a low velocity. So what can I do within that to expose him? And then ultimately kind of bring it back to when can he experience, even like an assisted pogo with a band was like right through his back. And it's interesting to think about because it can, and I think it kind of talked about this in this paper as well, of there's a kind of a bell curve of stiffness where you need a certain level, but being able to like zoom out and look at the whole person and say, okay, what does this person overall need? This person I'm talking about does not need to be more stiff. He needs to learn how to utilize that stiffness. But then of course, like he's in all this pain and then he went and played tennis. And I was like, how'd that go for you? Like terrible. I was like, great. That's good. So if anyone has any thoughts about that in general or have worked with people within that profile, I would love to hear that as well.
I have a question based off that, Alex. When you mean stiff for this individual, do you just mean like they're kind of a rigid human that just can't really do much to begin with? Because I think that's different than like tendon stiffness qualities.
Agreed. I think yes and yes. So one, rigid human, definitely. However, the way that he moves, he relies on what it appeared like from my watching him. It looks like he's relying on tendon stiffness or joint stiffness to be able to move through different ranges of motion or do certain things. And I've never seen him play tennis, but I can imagine it probably looks very similarly. So he's like created this very rigid body overall. And that I think it's both.
Yeah, for me personally, I think one of the things that I'll take as someone's ability to kind of express more movement variability is seeing like different ranges of motion that they can, train in. So for someone that it's gonna be quote unquote more stiff, and I'm thinking of that as like, when you're looking at gait, that's like plantar flexion, right? You're trying to get back into propulsion as quick as you can. So for someone that wants to become more compliant or able to express more variability through the range, I'm probably gonna test ankle dorsiflexion, see how that looks. If we can clear ankle dorsiflexion, but they can't tolerate the eccentric load, then I'm gonna probably have them do calf raises in the beginning. If calf raises are easy, then we can focus on the eccentric loading of the calf raise, and then I'll have them do almost like a pseudo pogo jump where you're coming down quick and you're trying to relax and contract back up again. So your foot never actually leaves the ground, but you're utilizing similar plyometric demands by by progressively overloading the eccentric portion of the calf raise. If that makes sense.
Yeah, it does.
But for me, like, it's always about figuring out, if someone's specific for a really long time, you're training plyometrics and you're always working on shorter ground contact times, you're going to get to a point where you can't be compliant enough to express that motion. So if you have a, smaller area of muscle that's being stressed constantly throughout the year, and you're not training any other areas, then it's just gonna be more provocative to those structures. So it's kind of like that balance is set in the paper where if you have too much stiffness, then the same joints and the same ranges are getting symptomatic. Whereas if you're too compliant, then that same stress gets distributed to the soft tissues. So part of, I think, figuring out what the intervention is also seeing what kind of injury the person in front of you is kind of recovering from, and then building the assessments based off of that.
Andy, how much of that though is going to be driven by just an alteration in mechanics from pain? Right? I mean, we're going to have different strategies. They may normally be incorporating an ankle strategy for their reactive forces, and then they move to a hip or a knee strategy, right? I mean, part of this whole process is finding that rate limiter, trying to eliminate that, but then we eventually do have to tie it back into what is their chosen strategy or what was their pre-morbid chosen strategy, and then how do we elicit that training to build up that profile, so to speak, of that capacity there. But I see a lot of patients that when they come in, their strategies are completely aberrant to what their normal movement patterns may be, right? I mean, if we're looking at gait and we're looking at things, and so I'm choosing a different strategy to avoid that pain, how are we breaking that out and being able to look at that? Or how are you doing that in your practice?
So I guess I just want to make sure I understood the question, kind of figuring out, is it a more of an adaptation from pain opposed to having an abnormal or quote unquote abnormal movement pattern? And how
right. I mean, when somebody presents in the clinic, they typically are presenting with a degree of pain. Well, looking at their movement patterns with pain, those typically aren't the pre-pain movement patterns. Sometimes they may be, but oftentimes we're making a large logic assumption that this is the movement pattern that led them to that pain, when we know that pain changes movement, right? So if pain is changing that movement, how am I sure that that movement pattern that they're presenting with is the movement pattern that led to the event in the first place? I think there's a logic leap that we oftentimes are doing, and that we're hoping that we're right, but we're not always sure that we're going to be right.
Yeah, okay, that's a great question. I think we're always operating with a degree of uncertainty, but it's got to be an acceptable degree of like uncertainty. We place a lot of emphasis on hearing the person's story because I think that gives us a lot of information as to what might be quote unquote a potential contributor. Using things like the contralateral limb might be useful, but again, it's just an inference at the end. But I'll have, someone tell me their story and I'm like, all right, if there's anything that you think might be relevant to how you're presenting, or when I assess some stuff outside, just let me know. And as we go through these low balance drills, like, oh, you know what? I forgot to tell you, the leg that I'm having a knee pain in, I've had like 3 ankle sprains or things like that. So these kind of things come up where it's like, okay, I don't think it, for me, it doesn't matter so much as to what is causing the change in movement, as long as we slowly, gradually progress them to something that's quote unquote a little bit more efficient relative to the task they're trying to accomplish.
That's fair. That's fair.
But it's it's hard to say because, again, we all know that like you can still be really resilient in different movement patterns, but sometimes, again, the cost of it might be what led them to the injury. But conceptually, I don't think it really matters because I'm going to still gradually progress them to what's more efficient based on what research shows in order to accomplish the task.
Andy, how much are you, they talk about in the paper looking at soft landings versus kind of like harder, stiffer landings. And I think Shelby, you posted about this a while back of like teaching some of the softer landings, is that like reducing performance? And then some of the like stiffer, harder landings, maybe it's potentially increasing injury risk, but it's also like you're probably going to be better at your sport if you have some of those qualities. So Andy, do you actually like teach people softer landings, or where do you find that middle ground between like producing and absorbing and having a little bit more stiffer kind of reactions and landings versus teaching softer, easier landings, or do you do both?
Yeah, there's a, in the end of the paper, I don't know why, but they put some guidelines for kind of progressing the exercises past the citations. And I really like, I don't really do this, you know, with progressing the exercises, I'm always looking at like how much load is being placed on the body. So cueing someone in like a softer landing is going to put less force through them. So it's just a progression from like, let's say you're doing a snap down, then you do a depth drop. I'm going to cue a softer landing in the beginning. Then I'm just going to kind of let them self-organize themselves. Like, hey, I want you to just land now. So in the beginning, I just want to see if they can tolerate it. Hey, land soft or like land like a ninja. I usually say something like, if you're jumping on your bed and your parents are next door, I don't want you to wake them up, and they'll try to land as soft as they can. And then that feels okay. Then, you know, you kind of let them do with it. Do another strategy. Like, hey, now I just want you to land really stiff. So I'll have them jump the same way, land like a ninja or land like your parents are next door. Then I'll actually move next to them and I'll try to, you know, push them, perturb them a little bit. And I'm like, that's the sensation I want you to get, is that when you land, you're trying not to be movable. So that's kind of the progressions that I go through when working on landing.
So there's a point closer to the end where you've completely removed softer landings.
Yeah, I think softer landings is only a way to kind of introduce force, because at the end of the day, you're trying to resist deformation in actual sports when you change direction, when you're trying to recycle force. So softer landing is a good way to kind of mitigate stress in the beginning to introduce the stimulus. But as you keep training, as you keep progressing your rehab, you got to get to a point where you're going to be quote unquote stiffer.
It's also just being able to express all of that, right? Because there's going to be a time where if I'm cutting, I may want to go into a deeper thing because I want somebody to pass me and then be able to explode out, versus when I'm going to jab step and cut across somebody, right? You want them to be able to have that full expression of any and all of those. And so it's being able to guide them through. Thinking of like an alphabet, you want them to be able to make as many words as possible so that they can create whatever book that they're going to write, right? So I just think of it as I'm trying to give them as many movement profiles and movement capacities so that they can choose in their task specific of their sport how they're going to express that, right? So I want them to have the capacity for all of those. And if I never give them the soft, then they don't know how to delay a cut to let somebody pass them so that they're going to, you know, go the other direction. So you need to be able to have that full expression.
No, that's a great point, Paul. And I think one of the things as you progress plyometrics, that's one of the things you'll get. It's like a 2-for-1, because you'll have longer ground contact times, but as you become more efficient at completing the task, ground contact times become shorter. So you, as you're progressing it, you kind of get that within the training itself as well. But that's a great point, because you don't want someone to just be, you know, exposed to one movement strategy, especially if the task is very complex and the strategies you're utilizing like fakes and stuff like that. you need to be able to express those different things. But one of those is, I think it comes with the training itself, because in the beginning, if the height's really high, you're going to see, you know, more knee flexion, longer ground contact times. But then as they get better, you're going to see shorter ground contact time. So that's kind of what I'm thinking, but that's a great point.
I actually kind of had a question. This goes back to Andy, you were talking about like, it depends what type of injury they had. And then kind of like when Shelby was talking about between, am I focusing on like the performance aspect versus like tendon stiffness? And I guess in the table as well, I guess I was wondering like, at what point in the rehab process does this become more of like, when do you start to prioritize tendon stiffness more? I'm just a student, and I was like looking at the table and I was like, okay, yep, that makes sense. Like sort of like a linear progression into the next phase. But I guess I was kind of wondering when, like, say, when would you even start like phase one? You know what I mean?
And everyone's going to have a different kind of guideline or like background. So, you know, there's certain research showing that you have to have like 1.6 times your body weight before like plyometrics become more effective, because you can have like a 1.6 times your squat and increase certain like plyometric measures. But, you know, when we're kids playing around, jumping around, none of us as kids can squat that much, but we're still doing a ton of plyometrics. So there's no like real like requisite strength that you need in order to start plyos. And I start them as soon as I physically can. So kind of to Shelby's point before, something as simple as a snap down, if someone can tolerate doing, you know, a body weight squat or like a goblet squat, you can probably get them to do snap downs, which is just overloading the eccentric portion. If they can do that, then from a snap down, you can do a little depth drop from 6 inches. Then you build it up to 12 inches. There's different rules of thought. I know Exos likes having box jumps. So you're going to jump into a smaller box, decreasing the vertical displacement over time. I personally just like dropping, because I think jumping up to a box the mechanics are a little bit different than actually practicing the landing, if that makes sense, Kevin. So that's kind of, for me, I try to get people into what we call pre-plyo drills as quick as possible, which is just the eccentric portion of the plyometrics.
Yeah, that's definitely helpful. Thanks.
What about all of what they mentioned with the consideration for the coaches of the technology, like the force plates, jump mats, GPS, treadmill with camera? Do you think that, one, do you use any of those? And two, does that change anything? Or do you feel like your eyes and the auditory nature of some of these movements, you can kind of like figure out when to progress and what they're looking like?
Yeah, that's one of the things where, like, when you look on the performance side of things, it just gets so expensive. For me, we don't have any of that in the clinic. I'm mainly using, and Chris Johnston has a lot of good posts about this, but using metronomes. So seeing what someone can tolerate with like a pogo at a set metronome beat, and then having an end point in mind of like where they need to be to return to running or certain sports. But like I said, I think you have this model of movement in your head, and as long as they're within that range that's acceptable, then you can just slowly progress the exercises. For us, I feel like it's more about, as a rehab professional, it's more about what can they tolerate now and how can I improve that over time, opposed to like really getting into nitty gritty of like what's their force velocity profile and all those things, which I don't think we have the equipment for. But there are simple things that you can see, you know, just like I almost think the assessment itself is also the exercise. So what's the lowest level of plyometrics this person can handle, and how can I improve this over time? And does it connect to what they're experiencing and some of the things that they're having trouble with? But I would love to get some of the equipment. It's just insanely expensive. But the app, the Just Jump app, I think it's like $10. I just haven't dived into that.
I have a question for anyone really. Kind of like thinking about kind of the specificity of the task. And like I work with a lot of youth athletes, so I think of, for example, an athlete in the fall season, like non-COVID season, obviously, but playing soccer in the fall and more like type 1 sport where you'd probably need a little more compliance and endurance moving to like playing basketball in the winter. where some of that stiffness and that ability to change directions quickly, like there's a higher frequency of those events. How much of it is them just simply playing the sport to have their body meet the demands of the sport, and how much of it is like, can we control? Because, you know, in my mind, I'm like, okay, like we can do all these box jumps for these athletes, or I mean, you can squat whatever percent of their 1RM that was necessary to, you know, increase stiffness and hopefully reduce injury risk. But how much of it is us training them, and how much of it is them just simply playing the sport?
And with a 12-year-old, are you worried about them signing a contract in the next year or two? Because my point is, with youth, more often than not, just giving them movement capacity and allowing them to explore movement in and of itself is really where we should probably be focusing, rather than whether or not I can squeeze out 2%, which may make a difference when we're on a very high end. But at a 12-year-old, 1 to 2%, I'm not sure that we're going to get much critical gain there that's going to lead to anything for them, right? Movement exploration and just playing multiple sports is probably where we should be pushing, rather than worrying about whether or not on their rate of force development is this much better for their particular sport.
Yeah, I agree with what Paul said. I kind of fell into that trap. We do like a youth athletic development class on Saturdays with a bunch of kids that are 8 to like 14-year-old. And I was like trying to keep structure in these classes. Like, hey, all right, in the beginning, we're going to work on some sprint drills. Then we're going to sprint. We're going to plyos. We're going to, you know, some squats. And then, you know, everything has a sequence. We're going power into strength and all that stuff. And I learned immediately, like, kids don't pay attention. So we go from like, all right, let's do 2 track drills. And who wants to go on a ladder? Who wants to jump some hurdles? All right. And then everything is just gamified and you're kind of thinking on a whim. But for me, similar to what Paul was saying, it's just making sure that I'm not doing anything that they're already getting. So I guess to put context into it is, if they're in season, I'm not going to make them jump more because they're already getting that stimulus. So they just have to explore different ranges of, you know, different planes of motion that they may not be getting. Even something as simple as just patterning over time. I really just want them to enjoy the sports more than getting into like performance end, because for kids, it goes over their head. So trying to embed certain skills into games is like key for me.
The Butler paper, they quoted another paper. I'm trying to find where it was, what page. I have the quote. Okay, it was on page 516. It was like right above the summary. It said, in another prospective study, Hewitt et al. Examined the effect of their jump training program on the incidence of knee injuries in female basketball, volleyball, and soccer players. And then they said the rate of knee injuries was significantly lower in the female athletes that participated in the jump training group. Therefore, it appears that individuals can modify their stiffness, and these changes in stiffness may result in a decrease in the incidence of lower extremity injuries. I read that and I felt like it was a bit of a stretch, because my question is like, was it the fact that they increased stiffness that reduced the risk of injury, or was it the fact that like they just had higher volumes of jumping? And that's where I feel like both of these papers have like a big shoulder shrug of like, we don't really know what to do. And I think that paper exemplified it, of like, you're making the conclusion that jump training increased stiffness, which increased resilience or reduced risk of injury. But, oh no, Andy left forever. But then my question is like, is that the case, or is it just we did more of the thing that we need to prepare for?
Well, hell, FIFA 11 Plus does it as well. I mean, they're not doing a whole lot of jumping, right? I mean, we do an intervention, we assume that intervention is the cause of those things, but just having people move a little bit more or gain a little more neural control or shit, just any application of something more, right? Is that what was really driving it? It's really hard to, there are, I think, a few leaps in some of the.
And while we're on the leap topic, on the same page, Chris, I'm glad you brought that up. Over in the left column, it says, Granada et al. Found that females demonstrated less knee stiffness during hopping than males. These authors suggested that this reduced stiffness may provide an explanation for the well-documented higher incidence of knee ligamentous injuries sustained in women. And I just thought that that was like trying to draw the dots very like in a non-scientific way. I just highlighted that. It seemed weak to me.
Yeah, I mean, I think everything is always gonna, that's a tough part, but like, reading research, because when you have someone in front of you, everything changes in terms of context and everything is different relative to the person in front of you. So kind of like what Chris said, like, is it the stiffness or is it their increased exposure to jumping? There's so many other factors that you just need, I guess, I always think like what's got an association, what's been shown to improve in performance, because trying to characterize people into like, hey, you need more stiffness or you need more this, that's why I'm always cognizant of it, because I'm not sure if I'm right, but I know that you're unable to, that's why everything is always functional based for me. Like, I know you can't tolerate this. In order to do your sport, you need to be able to do this. So let's kind of reverse engineer what the demands are and where you're currently at. And I'm going to give you checkpoints as to how we're going to get there. So before I can introduce all these other factors and the chaoticness that comes with playing sports, let's just stick with these basics, restoring range of motion, then integrating into these patterns that were previously provocative and then progressing those over time. And when it comes with plyos and, with lower extremity stiffness, that usually comes with higher eccentric forces over time. So it's so hard to like say certain things like that because it's a big generalization, but I think it holds a little bit of merit.
What about on the second paper or 2017 paper when they were talking about the inverse to stiffness is compliance? When would you want to, and I guess Alex, this kind of goes back to your guys' example of like you were trying to increase compliance maybe because they were too stiff. How is it possible to increase compliance and when would that be necessary?
That was one of the things like I was really thinking about as I was revisiting it again. And I like Paul's point about, having longer ground contact times, because essentially if you're experiencing longer ground contact times, you have to explore more range of motion opposed to shorter ground contact times. And the ability to do that really stems from what you have access to. So back to like the point with Alex is like, if someone doesn't have that requisite dorsiflexion motion in the simplest way possible, which is just checking active range of motion, then being able to integrate that into patterns probably unlikely. So seeing like, what does this person have access to? And then also looking at other things like with longer ground contact times, you're going to have more a deeper knee flexion angle. So if all the plyos you're training, you're just minimal, bend in the knee, and someone needs to be quote unquote more compliant, then I would introduce plyos or these tasks where you have longer ground contact times. But I think that might be more theoretical than, evidence. It's just more evidence informed.
Would you equate increased ground contact times is synonymous with increased compliance?
For me, yeah, because that's increased ground contact time. You're going to get more storage from the stressors. So increased ground contact time is going to be biasing more of a absorption opposed to propulsion. Like if it's like, absorption is kind of synonymous with compliance, and then vice versa for the other things. So it's kind of figuring out like if someone's coming off the ground all the time really quick, they're only expressing a smaller range of motion. Whereas if someone has a longer ground contact time, you have to get that range of motion coming from somewhere else. So you have to explore, larger ranges of motion. So for me, that's kind of my thinking about it. I'm not sure what the data says to support it, honestly.
I imagine, Chris, too, like the way that at least I'm thinking about it is if you're returning someone from an injury, and Andy, you were kind of touching on this of like, you might be cueing a softer landing earlier on and then progressing to letting them self-organize for what's going to be the best strategy for them. And then potentially even like you're probably reassessing and saying, is that the stiff landing I'm looking for? Or is that stiff propulsion I'm looking for? Or is that a product of, like, for example, in a post-op ACL patient, late stage rehab, that stiff landing can look to, or that short ground contact time can look two different ways. That can be something where you're like, I don't like that. Or yeah, you're doing a wonderful job of, getting off the ground, and this looks the way that I want it to look. Because I know, for example, I'm spending some time with Steph Allen right now, and she is a post-op ACL patient, and she's noticing every time this girl lands on her surgical side, it looks really straight-legged. And that's a kind of stiffness where I don't want that. But also it's informed with more context of this is a surgical side versus someone who doesn't have a surgical side or is healthy. Maybe that I'm okay with that. Does that make sense? I don't know if that's even remotely where you were going with that question, but
That makes sense for sure. Yeah.
No, I think that's a great point, Alex. Like, it's always relative to the person. So like when it like depends, it always depends. And I guess like to give you when it depends would be kind of like what Alex had that example. Another one would be, if, like I said, if someone is in season and they're already getting a lot of low, shorter ground contact time exposures, then their training has to be something that's a contrast of it. So that's why I would say you're gonna probably do more resistance training, things like that, where you're not exposing yourself to the same high eccentric demands for longevity. For like a, rehab standpoint, I feel like it's the same thing. It's just figuring out, and it's always back to function. Where are they at right now, and what can't they tolerate? And that's going to give me an idea of what they're lacking from a theoretical perspective.
There's the part where they talked about, and multiple parts of the paper, the 2017, with tendons capacity to store energy versus muscles. Is there ever a point in your head where you're like, okay, I'm going to do this exercise to practice like muscle stiffness or muscle storage qualities compared to tendon? Because obviously like each task is doing a little bit of both, but they mentioned like heavy slow resistance training will obviously bias more of like the muscle properties, whereas the faster, like shorter ground contact times will bias tendon. And maybe that's what you're saying, Andy, where like if they're basketball in season, they already have bias towards more of the tendinous like demands of the quicker ground contact. And so you would go towards more of the heavier, slower resistance side. Maybe that wasn't a question. That might have just been a statement.
I think I get what you mean though. It's like, are you thinking about like, what's the application for these different exercise interventions based on how the person's presenting? Like when would you pick one opposed to the other? Or like, am I ever thinking about I'm influencing the tendon more opposed to the muscle?
Yeah, probably both of those.
Yeah, I think it goes to like back to the patient story and what their profile is, because and where the person's experiencing the symptoms is going to kind of give you an idea of like, maybe we bias something else. So if someone's experiencing, let's say like Achilles tendinopathy, and you see them do like a hop task or something on those lines, and they don't have that range of motion or certain ways to distribute that stress elsewhere. Like let's say when they're doing it without any cueing, they're on their forefoot a lot. So it's just kind of jacking up the tendon. Then you might apply different strategies to increase ground contact time, see if that's less symptomatic, introduce, heavy slow resistance training or other things where you can still load the area in a more tolerable way. That makes sense.
Also going back to the 2003 paper, and it's sort of talking about like the different types of stiffness before it just like sort of lumps it all into just leg stiffness. I guess I was kind of wondering, it talks about like joint stiffness and like, does anyone who's like practicing right now like look at joint stiffness, or is it pretty much just like this qualitative how it's looking, how it's feeling for the patient or the athlete?
Define what you're talking about joint stiffness, because if you're looking at, like, if I'm thinking, am I looking at the movement arm of the joint, the range of motion, and then where their center of mass is relative to that? I'm not breaking anything out and doing any calculations to see what the torsional stiffness at an ankle joint is, right? That's just not happening, right? Do I look and see, okay, when they're looking and moving, am I looking at, okay, well, they don't seem to be compliant through the ankle, and they're just using a hip strategy when they land, right? So it's a very stiff leg, their ankle's not moving, the knee's not moving, and this. Okay, now I'm going to see, do we have those range of motion capacities? Do we have that they can actually express? Is that limiting them? Or is this just a chosen pattern because of X, Y, Z, right? So I want to know that they have those capacities, and then that's a chosen movement pattern versus they don't have that capacity to move through the ankle or through the knee. Therefore, they're forced into this strategy. So I look at it from that point of view, but breaking out, truly looking at, is this ankle as compliant as I need it to be in the total leg stiffness? Because I'm assuming that there's 20% here, 30% from this. And no, I'm not getting into those weeds, because that leads into, in my undergraduate's biomedical engineering, and we can start talking about a whole lot of other things that are lost in the efficiencies within this, right? And so it becomes way too complex to really try to do any of that kind of stuff. You're really just looking at kind of, where is their end task, what is the rate limiter here, whether their tolerance rate limiter, and then how do I apply that to get them moving along to the path of where we're trying to get to be. Which I really love that Andy's approach is that same thing. Where in this person's story does it fit? Where along that line are they, where I can find my minimal dose that's going to be effective, and then let's progress to where we need to get them to be. Because if you get into the biomechanics of this, you're going to get lost in the weed.
Cool. Yeah, that's helpful. Yeah, just like finding the, like, whatever part is the rate limiter for, you know, like the desired performance and outcome. That helps.
Yeah, and I don't want it to seem like, for me, this year is the year where I'm going to try to get better at taking objective measurements, and like, I'm like, man, I have to sacrifice a paycheck to do this. But it's one of those things you really have to do, because now I'm getting a lot more people that have had these, chronic ACL injuries, and they've never been able to perform the way they want to. So that, in that sense, when I'm returning someone, right now I'm using like a crane scale and stuff, but I need different things to measure different things. But it's the most applicable way I can always say, is kind of like what Paul alluded to, is you're just looking at availability for adaptability. So I'm always looking to see, what does this person have access to in isolation before I, see what it does in integration. And I think Eric Meyer had a great thing. It's like, if you don't have quad strength, you can't expect the knee strategy opposed to a hip strategy if they don't have that necessary load to tolerate it. So you can cue as much as you want, but if they don't have that requisite strength, it's not gonna, that strategy just is not gonna emerge based on individual's constraints. So I love what Paul said. It's just functional based, and it's in the beginning, but there's gonna be a time where you're gonna need some objective stuff to make a better decision.
Well, I mean, that's where we're talking about true performance, right? Because now those nth degrees of performance difference make a difference, right? For the majority of people just walking, wanting to play tennis or whatever, those 3-4% that we're going to squeeze out through having these huge degrees of certainty, which really, we could argue whether or not they're degrees of certainty or if we're just lying to ourselves a little bit, but it gives us those few degrees, right, of that nth degree. Because when somebody's running a 12-second 40, right, I mean, that, okay, I can get huge improvements, but when somebody's running a 4.2 40, am I going to get any improvement, right? So what are we looking at, right? What are those capacities? And gaining some on one end, I don't need a whole lot of specificity, but if somebody's running a 4.5 and wants to run a 4.2, I have to really look at how I can improve every last little bit of that. And that's a different talk than the early rehab or even any rehab, right? That is high-end performance, and that's a different human being, and that's a different lens in which we're having to approach things. Right. And in rehab right now, we're moving a lot of our thought process to this high end squeeze out 2%. and investing in a lot of things that really, for the majority of our patients, I'm not sure that it gives us any more clarity. And in fact, it may muddle the water with a whole lot of data that we really don't know what the hell we're doing with.
And I think the tough part is sometimes you can almost swing to the other side of the pendulum. You know, if you're too performance minded, someone that comes in, they're just getting all these measurements. They're like, all right, so how does this all relate to my story? And like, they're just being, it's almost like a different aspect of treatment where they're just being passed along these different assessments. You don't want to get into that point where you're not, you know, developing the therapeutic alliance and all the other things. So having a good way to assess these things quickly so you can get a general idea of what this person's lacking and then kind of building from there.
I have a question based off that, and this might be a tangent. So our MSK class, for our assessments, we're taught to find like lagging or lacking things like hypomobile segments, certain asymmetries, certain things, and it's more structural, so it's not really like kinetic focused or force production, but like in a sense, we're taught to look for something and then fix that thing. And that seems kind of similar to what you're saying of like, you're looking for the thing that needs to be improved upon, but how do we know that like that's what needs to be improved upon? Just because it's low or it's we found it in testing, how do we know that like that is actually what's going to provide change or valuable change?
Well, I mean, it goes back to the story that the patient is telling, right? I mean, is there a coincidence? And then are you able to reproduce their symptoms like in movement, right? Because I could care less if, okay, when you bend sideways, you have a hinge, but sideways doesn't provoke anything. Who gives a shit, right? I mean, those kind of things that are there that they're teaching in school, great. And you know, I mean, if you look at the human being in front of you, listen to their story, and then you're confirming a few hypotheses that you should be developing while they're telling you your story, it's a really quick entryway, right? Because now I'm not worried about all these little bitty details because I'm just confirming a certain thing that they're telling me through their story, and then I'm able to make that relevant to the human being and where we're trying to go with this. And I don't have to deal with 1,000 things and then try to put all the data points together on the test. They teach you in school, you're going to do all these tests, and then you're going to come to some kind of conclusion. Your shit and story should have already had most of the stuff to where you're getting down to just a few little testings that you have to do based off the human being story in front of you to confirm the direction that you're going, and then get on with treating and doing it, because this is a constant assessment, constant learning curve. If you think you know the shit from the eval, you're fucked. That's not the way that human beings work. You're actually constantly assessing, and you're constantly having to deal with the changes and the variability that is human beings, right? And so get onto it. Figure out a hypothesis or 2 or 3, have those there, have some concordant signs or things that you're going to use as your testing of that we're moving forward with, and then get into treatment so that you can see, are those things leading to resolution or not, and then be ready to pivot as necessary. People are going to come in after telling you that they can't move, and then they're going to go play tennis. Guess what? You're not going to get your scheduled plan done that day because you're going to be dealing with calming shit down, not building shit up. That's just the way that life is going to go when you're in the clinic. You just have to be able to have those hypotheses ready and working and then testing, but you're never going to know 100%. That's just, that's a fallacy.
And like, do you even care? I mean, at that point, it's like, if that's not consistent with the story they're telling you, it would be, it's a waste of your mental energy. And I find myself like, because I think because I'm still a student and it's something that comes up all the time, is like balancing the, does it matter or does it matter? Does it matter? Do I need to care about this? Stop caring. It's more simple than you think it is most of the time.
It usually is. Now, I will say, when you're dealing with very high-end athletics, right? When you're dealing with high-end performance stuff, now maybe that wiggling of this little thing makes a difference. Maybe. I will argue that oftentimes, if you look at the training of high-level athletes, they do circus tricks and it becomes cool, and that's what everybody wants to do. But they're doing circus tricks because they already have movement programming, they already have strength, they just need some rest on their joint systems and some novel stimuli to the body. And that's why that shit's working for them, not because it's anything special or magical. And we don't need to have them juggling with shit balanced on their nose on one foot. We don't necessarily need to be doing that shit just because that's what their pros are doing, because they've already shown the capacity to have all these other things. And this is allowing them to express something different in a different way. That's novel stimuli to the brain. That neuroplasticity and that stimulation is what's creating most of their gains that they're getting, and just a general active rest, right? Because they already have this shit and they already train at a certain high level. I think we can confuse a whole lot of stuff with what we see.
Yeah, I think one of the things, Chris, you're asking almost like, how do you know if, there's a certain quality that someone's lacking and you improve it? How do you know that was relevant to the person getting better? Is that what you're asking, Chris?
Right. Yeah. And I'm seeing it in school from like a rehab standpoint, but I could see it from like a upper, kind of what Paul was saying, like very high level sports of, now you have sports scientists and you have biomechanists and you have PTs and you have strength conditioning coaches, and they're measuring GPS and omega wave and XYZ, and there's so much signal. Like, how do you determine what's actually important?
Yeah, for me personally, like, I'm always trying to reflect on like how my systems are, how my principles and heuristics are as I'm treating. Like, if I consider something a KPI, then I have to revisit that KPI as someone's getting better. Is that KPI getting better and this person is performing better, pain's improving? And it's never going to be like, hey, there was a direct causation, but if there's a pattern that I'm seeing clinically, like, hey, if you're having, if you want to get back to running and you can't do a pogo jump, then the KPI is eventually going to be doing single leg pogo jumps to a set metronome. And, let's say you're back to running, but you can't do that. And, it kind of bothers you to run. But in the reverse, it's like, if you could do it and you're back to running, then you kind of keep refining your thought processes, like what really matters and what might not matter. Some of it's always going to be, and my bias is very biomechanics and capacity driven. I'm always trying to figure out what movements, and like, I'm always trying to give someone a problem they can solve that's manageable for them, and giving them hope through something like that. But again, if there's yellow flags and other things present, and I know that some of the thought processes might be inhibiting them, making them too hypervigilant on stuff, then I would spend a little bit more time letting them explore. But if I know someone's been having chronic issues and they've never received a really good chance at getting back at their sport because their progressions and everything were really bad, I'm going to explain that thought process to them of how you're going to be able to go from a lower stress, exercise to something that's a little bit higher impact, if that makes sense.
Yeah, that makes perfect sense. I can get on board with that for sure. You have to bounce in 6 minutes, right? Or a little bit under?
We got like lunch 12 to 12:30, but I had a big breakfast, so I should be good.
Dope.
But I think that's an important thing. It's one of the things that I picked up from, I'm not sure you guys are familiar with Chris Johnson, but he has a really cool return to run protocol and some objective measures that he's been taking that is a little bit evidence informed. And you can apply the same principles to just about everything. What when someone's performing a given sport, what are like the positions they need to be in, how fast do they have to get in and out of them, and how can you replicate those kind of demands with exercise is essentially where my head is typically at. And then reverse engineering the demands to like, all right, this is symptomatic for you. What's the most regressed version of that exercise that you can tolerate that I can prescribe? So for someone that's running, if the most regressed version of the exercise is calf raises, I'll tell people like, I'm stoked that you can do a calf raise, because just from being able to do a calf raise, I know you'll eventually be able to do a double leg pogo jump. Once you get to do a double leg pogo jump, I know you'll be able to do a single leg. And I start to connect the dots as to how these random exercises are relevant to where they want to be.
Andy, don't you think that that's part of the weakness within school? Is they don't teach you how to do a task analysis, how to regress that task, what the lateralizations, regressions, and progressions are, and then how to connect that for the person in front of you so that they see that it's leading to the goal. I think PTs, we typically do a pretty shitty job of showing how what we're doing is actually leading to that end goal. We just give them some exercises, do this, and then come back and see me and we'll do this and all that kind of stuff. I really think that we need to do a much better job of a much better job of being able to help that individual understand the stepwise progressions that we're looking for, understanding that it's a nonlinear progressions, but that we're going to be moving along this and that we're looking for these particular task-based type things rather than some of the, well, we're going to snap this, do this, and everything's in alignment and we're great, or some other kind of shit. Just looking at that task regressions and task analysis, because I don't think that, at least when I went through school, we didn't get a whole lot of good task analysis, right? We got good exercise, we got some of that stuff, but the task analysis, to be able to look at that, is one of the things that I think that we're lacking. And then really breaking it down, because that's a sports mind, right? That's a sports science mind of how fast are they entering and exiting a position? What is that position? What are the angles that are requisite for that? And then how do we regress that to that and make a lateralization? Because if you can't do this one, maybe you can do this one, and it's a lateralization rather than a regression or progression. And then how do we best march that patient along and then connect those dots for them so they see the value in what we're doing?
And that's like, I've done a business mentorship, and for me, the toughest part about that business mentorship was that I didn't have any clinical skills within that mentorship. That's business 101 already, you know, selling your plan of care, because it's not like you're being a sketchy salesman. You're generally interested in helping this person, so you can explain how valuable your thought process is, and connecting the dots from a single calf raise to all the way to, like, you know, being able to change direction and do all these things is seriously what's going to get that buy-in from people that, you know, want to work. Especially if you're working in an out of network practice, you know, it's a little bit more money out of pocket, but I have to show my worth, and I have to give them that roadmap of like, hey, you're here, this is where you want to be, this is every single check mark that you need to get before you get to here from a mechanical perspective. And that kind of goes into all the other things, because now you're giving someone a plan. If you give someone a plan, that gives them hope, and that starts to encourage all the other things that comes along with that.
Don't disagree.
What about upper extremity stiffness? What are your thoughts on that? Obviously, it depends on the sport and the, like, what they need to get back to, but do you see training that or looking at that, the like continuum of compliance versus stiffness, any differently than the lower extremity?
My goal for this year is to become a savage with upper extremity and cervical spine. So I'm honestly not that great with the assessment. I think the principles are still the same, but the biomechanics are a little bit different. I haven't like analyzed those kind of things as much, but that's something that I'm really gonna try to dive into a little bit deeper.
I imagine, like, totally speculatively, the fact that it's not a weight-bearing joint or not a weight-bearing limb would probably change a lot in terms of like the perspective on what stiffness is needed and in what capacity. Because if you are someone who participates in an activity that would be weight-bearing, that probably changes the stiffness expectation or stiffness demand versus someone who doesn't. I mean, it really then, is it stiffness or is it the ability to coordinate the joints in the upper extremity? Like, which would then be dynamic strength, theoretically. I do have a question for those of you that are practicing or even not. Like, so in this, which paper was it? The Butler paper, kind of toward the end, they cited Williams et al. And talking about like that there's this, oh no, before that, yeah. So too little stiffness may allow for excessive joint motion leading to soft tissue injury versus too much stiffness would lead to more of these like stress reaction and something like that. Do you find that kind of putting people into these two buckets based on their presentation helps you determine, maybe like this kind of goes back to Chris, what you were talking about with when someone needs more compliance? So I think a really easy example would be like runners, these runners that get these chronic tibial stress reactions. It gives you a really good picture of like what they're doing, and then they overcorrect and now they end up with Achilles tendinopathies. And so, but do you find that kind of classifying these people into what presentation do they have now, and that tells me where to go with them in terms of what they need, informs your process? Or is it not that simple, if that makes sense?
I think it's always going to be a part of the thought process, but it won't encapsulate everything that I do. It's a big part of, returning someone from a non-functional perspective to getting back to doing everything they want to be able to do. But let's say someone was already running, like you still have to consider like load management, all the other things before you even just directly correlated it to one thing. So that's where that's like navigating gray area. I've I usually try to get on a call with somebody before they come into the clinic just to screen if what we do is like appropriate for them. And if there's like during the call, I always ask like, has there been any changes in routine? And they're like, oh yeah, I've been doing this. I'm like, okay, do a little bit less of that, and then progress to this over time, and let me know if that gets any better over these 2 to 4 weeks. And if it doesn't, then maybe you can come into the clinic. But if there's a new, acute spike in workload, you might not need help, and I might not be able to help you. It's just this simple advice that, it's always just kind of figuring out. There's always a bunch of potential instigators, that could be the psychological stuff, the hypervigilance, the yellow flag. It could be the load management. It can be this really gray area we call like movement competency and movement quality. That's really hard to measure, and everyone's got their own biases there. So it's a lot of different things, and it kind of goes back to what Chris was mentioning. If something, that particular quality has to change if they get better. If they get better and that quality doesn't change, and it probably doesn't relate as much as we thought in the beginning, then we're just refining our processes as we go.
Yeah, for me, it's not you're in this bucket or you're in this bucket. Those are places that they have to move through, right? So like, I'm getting them through this movement capacity all the way back to what they want to do. And when we're getting to a certain point, we may be looking at, they need a little more and a little bit less, but it's not one of those things where, okay, you're here and this is the only interventions that we're going to be doing, or this, because that's not what a human being is. And they're going to change as they go through what we're doing with them, I would argue anyhow, right? Because some of the strategies, alluding to my earlier point, may be pain respondent strategies or other kind of things, and it may not be in the inciting event. And so if I just put them into a bucket and I'm doing this, I may put them into the wrong bucket, right? And so they may have been, it's part of the story, and it's something that you have to keep in mind, but their story is going to give you a lot more if you're asking some of those really elucidating questions of, have you changed your training? Have you done this? Were you having any kind of nagging niggles beforehand that we started to change how we were running around, or some of these other things? All those things come into it, and it's learning to parse those out and ask the right questions based off of those things, right? That takes just learning how to do that and getting to those good questions. That's why I applaud Andy for getting onto the phone. One, just from a business standpoint, you want to make sure that you have a good outcome with that individual. And that means that you're making sure that they're the right client for you, not just taking every client that comes in, and also just making sure that they actually need you. But it's one of those kind of things where you're looking at, okay, where in their scope and where in their story does this particular component of who they are fit in, right? Because they may just not have requisite strength, or they may be, oh, I've put on 30 pounds over COVID and I'm still trying to do the same mileage. Well, now we've got different stress. I mean, there's all that shit that comes into it that you have to look at. You can't just look through one prism and think that you've got it, right? Because we're far too complex of human beings to be lumped into just individual buckets.
Yeah, I find like thinking of things as like a sliding scale almost makes it a little bit easier to conceptualize. Like, let's say, for instance, like another thing to break down is, and I'm a big believer in like success leaves clues. So like people like Derek Hansen, Charlie Francis, these old school like track and field coaches, they have things where they split up sessions. One session's a top speed, the max velocity session. Another one is an acceleration one. So one's going to be shorter ground contact, one's going to be longer ground contact times based off the phase of the sprint you're in. So, you're talking to someone and all their training revolves around one particular stimulus, the same systems and the same tissues are going to get stressed. So something as simple as maybe just changing one day to a different stimulus is going to give someone a little bit more variability to disperse the stress to different areas. A lot of this is like theory, and I feel like that's half of clinical practice, is just creating a theory about what you think this person is lacking and then testing that theory. So the first session, I'll always tell people like, hey, this is my hypothesis. And this is where I think you need to go in order to get better. If you don't get better, we're going to keep looking elsewhere, and assessment keeps on going. But even if you do get better, you know, there's still so many other factors that I'll tell them like straight up, if it's acute, you're going to get better regardless. But I'm looking at things from a strictly performance standpoint for you, because I know you already have time on, you know, on your side, but there are other things that I think we can do to work upstream in order to improve your performance that I think you're, you know, lacking. And it doesn't have to be like I'm telling them they're dysfunctional. I'm just going to tell them that, hey, compared to like where you could be, I think these particular attributes or qualities can really improve your running pace, running economy, and things like that. So for it's always, I'm always trying to think of it as practical as possible and be as honest as I possibly can with the person in front of me.
This is off stiffness topic, but I'm curious how you run like physical therapy versus like performance training, because I'm sure you have like clients that you've seen for longer periods of time than like the normal PT model. So how do you, or maybe you don't, I don't know, I'm just making assumptions, but like how do you when someone comes to you, do you have like a specific like rehab package and a specific like now you're my coach or trainer? How does that work for you?
I think from day one, I'm always like trying to figure out, because you know, you'll get this a lot in the clinic. It's like, hey, what are your goals? I just want to get out of pain. Like, awesome. So there's like no direction in your rehab, because you don't know how you're gonna get this person out of pain. So I'll always ask like, all right, so you're in pain. If you weren't in pain, like what would you do? And then once they get a goal that's very specific with an outcome in mind, that's what we're going to work towards. So right off the bat, I try to show them that training is important for the task they're trying to accomplish. And that's my personal bias, because I know there's all the other influences, but I'm just saying for me, like I'm always looking at capacity. That's my lens, that's like my go-to. If I can typically rule out whether or not someone has yellow flags, then I'm going right into performance. I'm always looking at what this person can handle, and I'm going to show them what they can do and how to bridge that gap. So in terms of like packaging it for like rehab performance, I try to show them that it's performance right off the bat. You know, we're going to calm things down and stuff, but once we can do something as simple as the calf raise, it's performance. As long as you can do a body weight squat, it's performance. It's performance once you can do the most regressed version of your goal.
So when do you decide when it's time to not see a patient further or a client further? Is it up to them, or have you made it like, okay, this is the performance and we've reached that milestone, you don't need me anymore? Or do you not have that conversation? How does that go?
The conversation usually goes, you know, hey, we got to this point where you're able to do this now. You know, whatever their goal was. Like I just had someone that I was working with, MCL injury, returning back to soccer. He was able to play 2 weeks in a row, and I'm like, listen, I don't think you really need me anymore. Unless you want to stick with me and we can keep training together, you could, but I think I've already given you most of the exercises. Once these things kind of get pretty easy, you can come back to me for programming and we'll figure it out from there. But once someone can get back to their goals, I usually tell them, hey, like, I don't think you need me anymore. If you want me around for like programming once a month and once every other month, that's cool, but you're good to go.
Got it. That makes sense. So you have that conversation and then you keep it open-ended of like, if they want to continue, you do more of like a regressed version of seeing them, and maybe it's like telehealth or just email programming.
Yeah, there's a couple of different things. I have like some clients that come like every other week, some clients that come once a month. For me, when it transitions from like, hey, we hit your goals, if we have that conversation of like, we're gonna do, you know, remote programming or something else, I'm just gonna say, what are your goals then? Like, what do you want to be able to do? Because maybe their goals change now. Like maybe they have a moonshot goal. Like, you know what? I wanted to get back to running, you know, my 3 miles per week, but I actually really wanted to run a marathon or an ultra marathon. And I say, let's do it. Let's go. And then we'll start chipping away at that. So I try to have them have something in mind, opposed to like, hey, I just want to get into better shape, because that's tough. But if it's like, you want to get in better shape, like, do you want to learn how to swing a kettlebell? You've ever been interested in like barbells? So I try to get something out of them where they want to master a particular, you know, training, and then onboard them onto that.
And Chris, kind of going along where I think you're headed, of like, say, in an insurance model where you may have a cutoff point, or you may have something else that's kind of limiting, you still want to be able to have that conversation when you're approaching, like say for a total knee, when you're approaching the discharge date for the shit shower and shave capacity that insurance cares about, right? Let's look at whether or not we've got, now you stop doing things. You weren't playing golf because of your knee, right? Do you want to get back to playing golf? Do you want to get back to being able to walk the dog for a few miles for fitness? Do you want to do some of those things that they gave up prior to actually going to the knee surgery? Those are things that still may follow within insurance guidelines, right? Maybe not returning to golf, but definitely walking the dog or walking for fitness or health or some of those other things. And so you can actually, you reduce the number of sessions that they're coming in, but you're still involved in their care at that point in time. But then you're able to kind of look at, okay, what do you want to do? I mean, in my practice, right, that's where we're starting to have the discussions of performance, like getting you back into golf or helping you to do those other kind of things, right? So it's that kind of a shift when they're kind of, if they're insurance pay, then moving on to something else, because there is going to be a cutoff that insurance is no longer caring about that goal, even though it should be. That's a different discussion, but they really have a limited scope in some of those things. And so insurance may be the cutoff, or you have to look at how you can push still within the bounds, but push them up, maybe not the moonshot goal, but even what they didn't think that they could do after the total knee and getting them back in. I've had people return to skiing and do some of that kind of stuff that were total knees. You could argue whether or not they should be, but they had the capacity to do it. And that was really kind of what they wanted to be able to do, right? So those are the kind of things that you have to kind of balance within practice. But if you only go to that very low level, you're really not helping get them away from, if this is the life threshold and this is where capacity is, if they're just right here, it doesn't take much to drop them back into they're disabled. So you always want to push that capacity window up as much as you can within the realm of which you're working.
Nailed it, Paul. Okay. Do you have any more, or does anyone have any questions for Andy?
Yeah, I got a quick one just about like terminology. When you're saying KPIs, are you referring to kind of like an asterisk sign or like a long-term asterisk sign as something that they've been struggling with that's like relevant to their goals, and then something that you can look back upon like, oh, hey, we've improved on this thing? Is that kind of what you mean by KPIs?
Yeah, KPIs is key performance indicators. So certain things that you're hypothesizing that need to get better in order for this person to be able to accomplish their goals. So I'm using like, the running and the pogo jumps and all that stuff, because that, for me, those are certain KPIs I look at. Can someone do a single leg pogo jump for 30 seconds, 150 beats per minute before turning to running? And that's not something that I would say you have to be able to get, while you're running, but maybe you're returning to running and it feels good and you're not symptomatic for like the first mile or two. This is still something that you can do as part of your training to improve that over time as you build up your running capacity as well. So KPIs for me is just key performance indicators that I know these things are going to get better or have to get better in order for you to see some sort of resolution with your symptoms.
Got it. Thank you.
And sometimes they're very ambiguous. Like for me, it's not always like a quantitative thing. It could be qualitative, meaning having some sort of movement competency or movement quality. For instance, if you're assuming that someone's lacking strength in a frontal plane, how do you determine, what the basis of that is? Like, what are they unable to do in a frontal plane motion, and what do they have to be able to do in a frontal plane motion for them to feel better? And does that change when they get better? And does that change, frequently when you're using it as a KPI with all the clients that you're working with similar presentations?
Dope. All right, we can wrap it up here. Thanks, Andy. This is great, man.
Yeah, anytime. This was fun. I'm terrible at I talked to Chris before. I was like, this is some monster paper. So I didn't know what to present. I'd like a couple of things. And I was like, maybe throwing it out there was probably the best thing to do.
Yeah, for sure. That was awesome. Thank you all for joining the party. Next week's going to be Dr. Thomas Lee from Harvard. It's going to be epic. And then I have some people set up for February. But yeah, thanks again. And this is recorded. Yep. Okay, cool. All right. Y'all enjoy the rest of your weekend.
Thanks, Chris.
Thanks, guys.
Thanks,
Bye.
Chris.